Okay, so thank you for the kind introduction. Can you see it now?
Perfect.
Yes, yes.
All right. Okay, I'll keep it very brief because we're already short of time. So I will whiz through. So for introduction, I work in this place, which is in Adelaide, which is in the southernmost part of Australia. And just to give you an indication of what the country is like, it is a land of 25 million people. So, and if you compare that with India, which is about 1.4 billion, so the population of India is at the moment about 54 times that of Australia. So there is somebody who is not muted. Can I request that person to mute themselves? I'm getting some distracting noise here. Please mute yourself.
Professor of Pediatrics at GMP Bangalore is the IAP National Vice President 2020, past National President IAP Neurology Chapter, past President Secretary IAP Kerala Chapter, is also
Could you
been
please
editor
mute
Chief
yourself?
Medication of Trauma and Emergency Pediatrics, also Chief Editor IAP TV on
Hello,
TV book
could you
on
please mute
pediatric
yourself?
radiology, foundation pediatric
Organizers
neurology.
RX event, can you mute Dr. Krishna,
Is
please?
also the member of
Mute, yeah. Please go ahead, sir.
Okay, so I'd like to make a few acknowledgements here, as I could see it here, reference articles from various journals. And again, starting off with this particular quote, the humanity has three main great enemies: fever, famine, and war. Of these, by far the greatest, the most terrible is fever. So it was by none other than William Osler. So the scheme of the presentation today for the next 15 minutes is that I don't have any conflicts of interest. I haven't received any funding or any support for this talk. It's entirely my own contribution. And what I'm going to do now from here on is to just talk about why is fever in ICU an important issue? What is fever in critically ill patient? How does this occur? The pathophysiological basis, what causes this? And then we'll travel through evidence-based medicine. I would aim to give a synopsis of observational studies and of randomized controlled trials, and then finally summarize and give you at least a couple of take-home messages. So I was given this topic and I was asked that it is an open problem. And then I wondered as to what is meant by an open problem. So in science and maths, this is called as a problem, which is something that can be accurately stated and which is assumed to have an objective and a verifiable solution, but which has not yet been solved. Okay, so one of the things there is about the four-color theorem. So what it actually means is that, if you are looking at these maps here, and this is just to give an example, the four-color theorem is that if you want two colors not to be the same next to each other, and what is the maximum number of colors that you could use to try and prevent that from happening, you only need about four colors, and then you can achieve to solve the problem. So this is important here from a fever point of view, in particular as to why this is an issue for us. Okay, it is not about what is fever or how it happens, but why is it important? So it is common in ICU. It has potential benefits and potential risk for patients. And among patients who have infections and who are admitted to ICU, increasing fever is independently associated with a decreasing risk of in-hospital mortality. Even in the absence of infection, a low-grade fever appears to be independently associated with reduced mortality risk compared with normothermia. So the what of it, definitions vary. When do you call someone as febrile? If it is 38 or 38.3, but for practical purposes in an ICU in Australasia, we would use 38.3. And the measurement techniques, as you can see over the years, we have diversified from starting with an axillary thermometer to currently using, temporal arteries, and more importantly, using, advanced gadgets. But nonetheless, the principles remain the same. So in terms of the pathophysiology of fever, most are mediated by the production of pro-inflammatory cytokines, interleukins 1, 6, and TNF-alpha. It's also important to understand that it is the reset of the hypothalamic set point, which is increased, and then the prostaglandin E2, which is involved in this. It causes vasoconstriction, it increases metabolism and muscle contraction. And the hypothalamic set points are lower, and then as a consequence, you will feel hot and sweaty when it happens. So as you can see here, the exogenous pyrogen starts off a cycle, the leukocytes are activated, the interleukin 6 is proliferated, and along with the other cytokines, as we spoke about, it affects the circumventricular organs, release of prostaglandins, and then it has a feedback loop. So there are several phases here, as you can see, starting over the chill phase, the plateau phase, and then eventually the defervescence as it happens. So the mechanisms of that, along with what I said earlier on, is also how it, overall affects the functionality of the hypothalamus. At the same time, it causes mitochondrial and DNA damage, especially in those patients who have hypothermia. and it also causes stimulation of the exotoxic mechanisms and causes protein denaturation and cell death along with it. It's not only what happens at the cellular level, at a local level, there is cytokine stimulation and inflammatory response along with vascular stasis, and subsequently to that you have endotoxemia and gut bacterial translocation, which are some of the consequences of hypothermia. So there is a key difference here. What is the difference between fever and hypothermia? What we mean by that is that fever is 38.3 and above, and hypothermia by definition is usually 41.1 degrees centigrade and above. So again, I've borrowed from UpToDate here about quite an important slide in relation to what are the mechanisms by which we use various agents at several stages. We use corticosteroids, antipyretics, and dantrolene. And again, as you can see, it's self-explanatory about the various sites of action in terms of its effect on interleukins and TNF-alpha, antipyretics having their effect on the prostaglandins, and dantrolene, which thankfully we don't see it very often these days, unless you have had an issue with malignant hypothermia as a consequence of an anesthetic, which tends to happen very rarely. I have only seen it once in the 17 years I've been practicing in Australia. So benefits. So when I say fever can have benefits, people might look at me and think, well, what am I talking here? Because it's always associated with a negative connotation as to someone having fever. But at the end of the day, fever is a symptom and it is not a diagnosis. So that is very, very important for us to understand. So when we have people examining patients and coming to us and saying the patient has got fever, yeah, that's right. But why has he got a fever? You tell me why, not what. Okay, so fever can be a good prognostic sign in acutely unwell patients with infection associated with a very high rates of survival. In a prospective observational studies, which have been done on one occasion, the fever inhibited microbial reduction and viral replication, as well as accelerated the rate of phagocytosis. The heat shock proteins, again present in fever, are thought to prevent thermal damage to cells by inhibiting the pro-inflammatory signaling pathways. And again, if an individual is able to mount a febrile response, you have to assume that the person has got a good immunity and has also has got a good prognostic sign in terms of their longevity compared to those patients who are unable to do it. So, and again, that is a good evidence to back that with the evidence suggested there. So coming to the causes of fever, in broader terms, infectious versus non-infectious. So one thing I would like to say is that, the population in Australia and the types of infections we see are slightly different to what would happen in India for that matter. Okay, but nonetheless, the causes of non-infectious fever are probably more. So the diagnostic approach depends on the magnitude of fever elevation, fever pattern, the relationship of pulse to fever, and the presence or absence of localizing signs. The thresholds are important, extremely important. So 41.1 degrees centigrade and above, you have to assume that there's something else going on, not just an infection. Could be malignant hypothermia, could be a centrally mediated process like a hypothalamic dysfunction from a stroke, either a heat stroke or drug fevers. One thing I would say is that heat stroke is quite common in Australia because it is an arid land, it is dry, and it does suffer from bushfires time and again. So it gets really hot. 2/3 of the continent of Australia is desert. So we are prone to developing heat strokes here. But having said that, with climate change, we are facing quite unpredictable weather these days, and it is not always the case. But either way, it is not uncommon to see heat strokes in Australia. And there is no prognostic significance in terms of the temperature difference between 38.9 and 41.1. In terms of the infectious causes, it won't be vastly different to what you would see in an Indian ICU. Bacteremias, catheter-related infection, surgical site infection, ventilator-associated pneumonias, and UTI. The stock standard ICU-related infectious issues, nothing changes. The other infectious causes, again, is a vast variety here. I'm not going to read out everything. I'm sure all of you are able to comprehend what that would mean, but suffice it to say that we do see quite a bit of empyemas here, more than you would think. Endocarditis, again, mainly because we have a significant problem with intravenous drug abuse in this part of the world, and necrotizing soft tissue infection or necrotizing fasciitis. Again, it's quite an important issue for us. In terms of the inflammatory pathology, again, you will be looking at burns, trauma, and surgery. We are a quaternary referral center, so we get a lot of burns patients for the entire Central Australia. So again, that would be one of the major reasons we find non-infectious fever, pneumonitis, ARDS, and again, the other granulomatous diseases, which are tend to be more prevalent in this part of the world. Infarction, either myocardial or cerebral, along with gut and pulmonary, not an uncommon cause of fever. The hem-onc and endocrine group of patients, again, it is important to realize that we do see more of pheochromocytomas and thyrotoxicosis here, along with tumor lysis syndrome and malignancy from a hem-onc point of view. Tumor lysis, again, we have seen quite a few of them, mainly because we have a very large catchment area for oncology patients. And then finally, in terms of the other causes, again, a vast variety of reasons here, and more important to realize that, the drug withdrawal or overdose is not an uncommon problem in this part of the world. Now, coming to non-pharmacological means of reducing the temperature in terms of cooling, cool environment, wet towels, ice packs, blankets, etc. Is there any evidence to support this particular theory? The answer to that is yes. This is a journal from the CCR, which is the Journal of the College of Intensive Care Medicine in Australia and New Zealand. We showed that active temperature management neither increased or decreased mortality in critically ill adults. And then if the approach is to reduce body temperature, physical cooling may be more effective than pharmacological measures. Okay, so this is again a proof of concept, but again, I would say it's reasonably high quality evidence because it was from a systematic review of and meta-analysis of randomized controlled trials. Now, coming back to the areas here, as I would like to focus in terms of what actually happens in terms of the temperature, and again, this is from Hutchison's, in terms of the sweating and vasodilatation as to which areas are involved. It's the involvement of the parasympathetic and the sympathetic nervous system. This parasympathetic gets activated and the sympathetic nervous system get inhibited in response to this, the fever issues, which happens along at the same time. Now, looking at the observational studies for fever and fever management, there's quite a few here which have been done, but I will go through the key studies which will lend some thought to where we go. So a fever of 38.3 developed in about 44% of ICU admissions in this study, which was a retrospective cohort study. And they found that it was neither associated with increased ICU mortality, but high fever beyond that was associated with significant increased risk of death. The study by Young et al., and that's from New Zealand, but it was done in Australia and New Zealand over a 6-week period. They found that 9% of patients admitted to ICU had or developed a fever or known to suspect infection. Paracetamol was admitted at least 2/3 of the fever in that particular group of patients. NSAID use was independently associated with increased 28-day mortality in patients with sepsis, but a trend towards a decreased mortality in patients without sepsis. And this paper found that 25.7% of patients had fever at 38.3 at ICU presentation. Fever was not associated with increased mortality, but hypothermia was an independent predictor of death. So hypo, as in low temperature, is an independent predictor of death. Is severe, is associated with worse outcomes than with fever. So fever does not always mean that it is associated with increased mortality. And this is a paper I would like you to remember. And if there's one take-home message, I'll probably focus on this. This was a retrospective cohort study, as you can see, of a significantly high number of patients, almost like 6.3 lakh patients in Australia, New Zealand, and the UK, admitted to ICU over a 5-year period. And they found that elevated body temperature in the first 24 hours of ICU was associated with an increased risk of mortality in patients without infections and a decreased risk of mortality in patients with infection. So if you have an infection and if you have a low-grade temperature, something which is not actually compromising cellular function, it's actually not a bad thing. That's the take-home message. So let's not be too concerned or too overreactive or too paranoid about just treating the numbers. We need to treat the patient in front of us and not just the number. We look at the randomized controlled trials here in the management of fever here. Again, this paper said there was no significant difference between brufen and placebo. And this is mainly looking at NSAIDs as well. And again, in this paper, again, using NSAIDs, no significant difference between the treatment groups with respect to ventilation requirements. And again, in the final paper, external cooling devices did not alter the proportion of patients who had any reduction in the vasopressor requirements. And there was a meta-analysis which came about on a systematic review for patients with COVID. It would be remiss of me if I don't talk about COVID in ICU, particularly with fever. And there was some bad press for NSAID saying that they increased mortality, particularly in the initial wave, which affected Italy. But this meta-analysis actually said that NSAIDs are not too bad overall. This came out in the eClinical Medicine, and that was a study which said, look, it is something which we have to take it with a dose of caution. In terms of the acetaminophen for fever, again, early administration of paracetamol to treat fever did not affect the number of ICU-free days from the NIJM paper. And again, from this, this was from the HEAT study from Australia and New Zealand. And finally, in terms of the meta-analysis in this group, we found that, again, looking at individual patient data, quite a lot of papers were controlled in this study. They found that do not support the hypothesis that active fever management increases survival compared with less active fever management overall or in patients with limited physiological reserves. So in summary, what is the take-home message? The cornerstone in the management is to seek and treat the underlying cause. There is a certain degree of clinical practice variation that exists in the management of fever. A subset of patients will need closer attention in the ICU context, and that would include patients with neurological conditions, post-surgical patients, pregnant or immunosuppressed, malignant hypothermia, or neuroleptic malignant syndrome. However, fever is not a bad omen. Okay, a less is more approach in the management of fever is entirely appropriate. Active fever management does not improve survival overall, and in those with limited physiological reserve. It's actually not an open problem anymore, in my opinion, I have to say, and it can be considered as an open and shut case based on current evidence. I will conclude my presentation here and happy to take any questions. Thank you.